Hello everyone, Drew Thompson once again, speaking to you from the Division of Emergency Medicine Point-of-Care Ultrasound program at Western University. Welcome to this installment of our Practical Point-of-Care Ultrasound series. The goal of this session is to define the positive female pelvic study in the first trimester patient and reinforce the criteria required to declare an intrauterine pregnancy on bedside evaluation. A subsequent screencast will provide a review of the clinical pathways that accompany this study, as well as some practical cases. As always, please be sure to visit us at WesternSono.ca for all of our updated ultrasound resources. Now that you're familiar with the scanning techniques of the female pelvis, we need to define the positive scan. What is it exactly that we are asking clinically? And what are we looking for on point-of-care ultrasound? Recall that the most common presentation that may lead to a pelvic study is in females of reproductive age who are pregnant or possibly pregnant and presenting with abdominal pain, vaginal bleeding, and either presyncope or syncope. When faced with these scenarios, we are really asking ourselves, does this patient have the dangerous diagnosis of ectopic pregnancy? Of course, if we can effectively exclude ectopic pregnancy and take it off of our differential diagnosis, then we will also be asking, can we gather more information about the pregnancy at hand? When using point-of-care ultrasound for early obstetric assessments, one might assume that we use this tool to look for the concerning disease, a potentially life-threatening ectopic pregnancy. However, these pathologically positioned pregnancies can be very difficult to find. They are small, they are in areas traditionally more difficult to assess sonographically at the bedside, and even with extensive experience and training, often remain elusive to ultrasound detection. Furthermore, ectopic pregnancies can become complicated even before they become apparent on imaging. As such, the hunt for an ectopic is simply not a realistic goal of bedside ultrasound. The good news is that a normal intrauterine pregnancy, or IUP, is something that can usually be seen at the bedside, with the obvious caveat that gestational age matters. In most circumstances, once you have confidently found and declared an IUP, then the diagnosis of ectopic pregnancy is effectively excluded as a cause for their presenting symptoms. Therefore, a positive pelvic OB study is achieved when an IUP is confirmed. Let's take a moment to review our other positive findings in our basic applications and see how the OB study differs in this regard. If you recall, in our other basic applications, we usually ask ourselves, do I see markers of pathology? For example, in the aortic study, do we see dilatation of the aorta? If so, then this is a positive study. It is positive in that we have identified the pathologic state. In the subxiphoid cardiac assessment, we ask, is there fluid in the pericardial space? And in the abdominal component of the FAST exam, we ask, is there evidence of free fluid in the abdomen? If so, then all of these questions are positive for potential pathology. Contrast this to the pelvic OB study, in that here we do not look for the pathology, but rather we look for the normal. We look for the IUP. Why does this matter? Well, for the aorta, cardiac, and FAST exams, above all else, we do not want to miss the pathology and have false negatives. Whereas in the OB exam, of prime importance is to not overcall normal intrauterine pregnancies and have false positives. To do so would be extremely dangerous, as one would then dismiss the life-threatening ectopic pregnancy, potentially putting the patient at peril. For this reason, the obstetric scan in first trimester is arguably the most dangerous study you will perform. You must be confident you are seeing an intrauterine pregnancy and be very careful not to overcall your findings on screen. To reiterate, in the vast majority of patients, once you have confidently declared an IUP, then ectopic pregnancy is effectively excluded as a cause for their presenting symptoms. It is worth noting, however, that there are patients considered high risk for a heterotopic or simultaneous ectopic pregnancy. In these scenarios, not only do they have an IUP, they also have a concurrent ectopic gestation. Although extremely rare, and you'll see risks between 1 in 8,000 or 1 in 30,000, they are considerably more common in women undergoing infertility treatment and ovarian stimulation, where the risk of a heterotopic gestation may be as high as 1 in 100. The risk will also be elevated in areas of endemic tubal disease owing to chlamydia and gonorrhea. In these higher risk patients, an IUP is very reassuring, but if symptomatic, elective imaging should be arranged as well in order to get a good assessment of the adnexa. Before we are able to use our point of care study to look for true positives, we must first review a few of the simplified stages of early pregnancy development and correlate these with sonographic findings. Many changes occur in the uterus and endometrial lining early in pregnancy. Ultimately, these will culminate in the obvious structure of a visible fetus. During this series of developmental events comes a stage where we can identify a set of structures that clearly defines that the pregnancy is developing in the uterus. It is these criteria that we must look for and identify with certainty before we declare an IUP. The terms and structures with which you must become familiar include decidual reaction, gestational sac, yolk sac, and fetal pole. Although the timing of appearance of these structures is reasonably predictable, we will not be using these to make our decisions in point-of-care ultrasound. Instead, we must identify these structures to assist us in the interpretation of our generated images. So let's take a closer look. Here we see a stylized diagram with a solid organ density representing the uterus. Within its confines, at the middle of the uterus, lies the endometrial canal, the endometrial stripe on our ultrasound images. If this image is identified when scanning a pelvis, obviously this does not represent an IUP. As the cascade of early pregnancy unfolds, and as implantation of the embryo occurs, the endometrium undergoes a decidual reaction. Although this structural change can be defined by several descriptive, anatomic, and sonographic layers, in our simplified approach, we will visualize this as a generalized thickening of the endometrium occurring around the site of the presumed embryonic implantation. In and of itself, this thick echogenic lining does not define an IUP. Here we can see an example of a decidual reaction in a transabdominal longitudinal study. Note the highly echogenic, thickened area at the center of the uterus. This is a decidual reaction. Here is another example of a decidualized endometrium. In this transvaginal sagittal study, we see focal thickening of this echogenic layer at the middle of the uterus. As the pregnancy develops, eventually the next identifiable structure will be a gestational sac. The gestational sac appears as an anechoic, fluid-filled sac that is contained within the decidual reaction. Normally it appears round or oval, and it seems to have a fullness to it. One must be careful, as a gestational sac, even within the decidual reaction, is still not definitive proof of an intrauterine pregnancy. Depending on the technique used in scanning the pelvis, we may begin to see the gestational sac around the 5-week mark with the transvaginal probe, and about a week later if we're limited to transabdominal scanning. Again, for the time being, we are focusing on our image interpretation. As such, the predicted times of appearance of structures is really not all that helpful at this point. Here we identify the transabdominal longitudinal uterus, and within it we see an anechoic fluid-filled structure surrounded by a decidual reaction. It appears full with a nice smooth border. This is a gestational sac. We can see similar findings on this transverse scan of the uterus. An anechoic gestational sac surrounded by a decidual reaction, all contained within the confines of the solid organ density of the uterus. As embryonic development unfolds, we next find another thick echogenic layer appear within the gestational sac. This is the yolk sac, and it is the first structure to appear within the gestational sac. The yolk sac is a symmetric, circular echogenic structure at the edge of a gestational sac. As you develop your skills in first trimester scanning, you will recognize this structure as a Cheerio within the gestational sac. The white, hyperechoic ring of a yolk sac within a decidualized gestational sac makes up the double ring sign. This is definitive evidence of an IUP. Again, the yolk sac will usually make its appearance between 5 and 6 weeks on transvaginal scanning and a week later on a good transabdominal scan. On this coronal transvaginal image, we see a nice Cheerio within the gestational sac, making this a yolk sac. Together with the surrounding ring of a decidual reaction, we have a double ring sign. This is confirmatory evidence of an IUP. Here's another example. On this pelvic longitudinal image, within the gestational sac, we identify the Cheerio of the yolk sac. This is an IUP. How about this transverse scan of the female pelvis? Are you confident you can identify the yolk sac? Shown here within the gestational sac and also surrounded by decidual reaction, we are confident that this is an IUP. The fetal pole is the next visible structure to develop within the gestational sac. The fetal pole begins its development at approximately the same time as the yolk sac, but will not usually be seen until about a week later. Likely we will see a fetal pole around the 6-week mark on transvaginal scanning and between 7 and 8 weeks on a transabdominal scan. It will initially be seen as a small mass at the margin of the yolk sac. To qualify as a fetal pole, we should see it as a discrete mass, separate from the gestational sac wall, and it should have some organized structure to it. Once it reaches 5 millimeters on transvaginal scanning, or 10 millimeters on transabdominal scanning, we should be able to identify fetal cardiac activity within it. When observing a decidualized gestational sac, the presence of a fetal pole, especially with cardiac activity within it, is another definitive finding of IUP. In this still image, we see decidual reaction, a gestational sac, and a structured mass distinct from the wall of the gestational sac, that is, a fetal pole. This is an IUP. When beginning your scanning, an extra layer of safety is afforded if you restrict yourself to only calling a fetal pole if you see cardiac activity within that structure. Here is another example of similar findings. The visible, organized structure within the gestational sac is discrete from the wall and qualifies as a fetal pole. Again, to be safe, be sure to inspect it for fetal cardiac activity. We have now defined our criteria to declare an IUP on pelvic scans. At a minimum, we need to see a decidual reaction, a gestational sac within it, and we need the third criteria. We need something structured within the gestational sac. This will either be the chiro of a yolk sac or the discrete structure of a fetal pole, preferably with a fetal heart rate within it. You must be rigid with your assessment for these criteria, as without all three criteria, it is still possible that the pregnancy is not developing within the uterus. Here are two more examples of intrauterine pregnancies. On the left, a transverse scan of the female pelvis. We identify the gestational sac, surrounded by decidual reaction, and within it we see the chiro of a yolk sac. On the right, a longitudinal female pelvic study. We can identify decidual reaction, a gestational sac within it, and we see our third criteria, a discrete mass separate from the gestational sac wall, qualifying as our fetal pole. Both of these studies are definitive IUPs. Let's turn our attention to another term, LIUP, or live intrauterine pregnancy. This further classification of the pregnancy really falls into the category of nice to know, but not need to know. As long as you've declared an IUP, you are being safe. As always, there are a few issues that you must be aware of. One may make such a call of LIUP as long as the cardiac activity is being observed within the fetal pole and is clearly distinct from the wall of the gestational sac. Recall that maternal pulsations will also be present, so the two should not be confused. Be sure that you scan in two planes to increase your confidence in this assessment. The normal fetal heart rate should always be greater than 100 beats per minute, and its presence is very reassuring. If fetal cardiac activity is healthy near the end of the first trimester, the risk of subsequent miscarriage is very low. Unless you have concern for a heterotopic pregnancy, your workup of the pregnancy can end here. The patient can be discharged to their primary care physician with instructions to return if any new or increasing symptoms develop. However, if the fetal heart rate is less than 100, keep in mind that embryonic bradycardia predicts a poor prognosis for this pregnancy. In this situation, you have still documented an IUP, so the risk of ectopic is eliminated in most circumstances. However, in this case, one should always arrange follow-up with formal imaging or outpatient gynecology because of the concern about a possible imminent miscarriage. As a final note, please be aware that the Doppler mode on your ultrasound machine should never be used in transvaginal assessments of early pregnancy, owing to transmission of energy to the embryo and possible risk of fetal malformations. Both B mode and M mode are considered safe approaches. Let's take a look at an example of an LIUP. During this clip, we identify our cardinal features of IUP, including the decidual reaction and gestational sac, and within them we see a discrete structured mass. On closer inspection, we identify fetal cardiac activity, greater than 100 beats per minute. This is an LIUP. Here is another example. Note that on this clip, at the 12 o'clock position, one may wonder if there is also a yolk sac present. It is not distinct enough to be sure, so it would be best to scan in another plane if this was our only criteria to define an IUP. However, in this case, the fetal pole satisfies the third cardinal criteria, and this is an LIUP. By now, you should realize that we are very emphatic that you must have all three cardinal findings on your bedside scans before you safely declare an IUP. The simple fact is that both decidual reactions and collections of fluid in the uterus, presumed to be gestational sacs, are not enough to be proof positive that we have an IUP. They are in fact signs of early pregnancy, but they are not 100% reliable. Case in point is the pseudo-gestational sac of pregnancy. These are present in 5 to 10% of ectopic pregnancies and may mimic a gestational sac. They represent a breakdown of the endometrial lining due to the influence of the hormonal cascades of early pregnancy. They often have less of a true decidual reaction surrounding them, and they often look less full, irregular in the appearance of their contours. Be careful, without a clear Cheerio of a yolk sac or a discrete fetal pole with structure, then one must not make the call as IUP. To do otherwise is an egregious error in patient management. One final area of risk exists when confirming your IUPs. Rarely, a pregnancy can implant itself in the horn of the uterus, an area where there is little thickness to the myometrium. Imagine a pregnancy developing here. As it grows, there is a high risk of rupture of the thin myometrial mantle surrounding it, posing significant hemorrhagic risk to the mother. So how do we protect ourselves against this risky scenario? One must always be sure to measure the amount of myometrium surrounding the pregnancy and accept no less than 8 millimeters at any one point. If you do find an equivocal or concerning area, be sure to have that patient properly imaged and referred, as these are high-risk pregnancies. Here is a scan showing us our cardinal findings of intrauterine pregnancy. However, there is some concern about the thickness of myometrial mantle surrounding it. This patient should be evaluated formally. We have one final scenario yet to define. That is when you do not identify all three cardinal features of intrauterine pregnancy. Perhaps you see a decidual reaction, a gestational sac. But if you do not see the yolk sac or fetal pole, then you must make the interpretation of NDIUP, no definite intrauterine pregnancy. Of course, there are many reasons that you might come across an NDIUP. Perhaps you are too early in the stages of gestational development. Perhaps this is an ectopic pregnancy. Perhaps this is a miscarriage and the uterus has yet to evacuate itself. Once you make the interpretation of NDIUP, you should take a close look at the pelvis for free fluid and move your probe upwards to the upper quadrants to be sure that there is no free fluid on the abdominal fast exam. So let's review our overall approach to the first trimester scan. Well, we know we're not going to ask the question, is there an ectopic pregnancy? Rather, we're going to ask, is there confirmatory evidence of an IUP? If we satisfy all the necessary criteria, then the answer will be yes, positive for IUP. We will consider the rare circumstances that elevate the risks of heterotopic pregnancies, but otherwise we can be confident that we are not dealing with an ectopic gestation. If we can clearly see the entire uterus, but not meet the criteria to be certain that there is an IUP, then we interpret our scan as NDIUP. In this case, the broader clinical picture must be considered and the potential risk of ectopic must weigh into the decision making. Is the patient stable? Do they have free fluid in the pelvis or the upper quadrants? Are there concerning features that merit immediate referral? Can this patient be managed as an outpatient? We will tease out some of these decision pathways in a subsequent screencast, although as always, clinical suspicion and concern reigns supreme in these matters. And of course, it may very well be that your generated images are simply not adequate enough to make a call. This usually occurs when scanning a patient with an empty bladder and the scatter artifact from bowel does not allow the full assessment of the uterus. To make a determinate call as either an IUP or an NDIUP, one must first be sure you can see the entire uterus. Not infrequently, you will ask that patient to fill their bladder and repeat the study. As a reminder, as you archive your studies in QPath, be sure to document your interpretation on all of your OB scans. There really are only 3 choices that you need to entertain: IUP, LIUP, and DIUP. Be strict with yourself and manage your point-of-care assessments safely. So this concludes our screencast aimed at defining the positive female OB study. Our next installment will include a discussion of the clinical pathways and several case examples that accompany this application. We hope you find these resources useful, and please continue to follow us at WesternSono.ca.